I'm Dr. Michael DeTola.
And I'm Megan Strong.
What are the three best sequels in history? There's The Godfather 2, there's The Empire Strikes Back.
Alvin and the Chipmunks 2, the squeakquel.
The acting was good, but the plot had more holes than Swiss cheese.
Caddyshack 2?
No, you can't put it in there. Bill Murray wasn't even that. He refused to do that project because it was horrible. No, it's part 2 of our exclusive interview with Dr. Gordon Christensen. That and more on today's Chairside Live. Welcome to episode 34 of Chairside Live. Megan, how are you doing?
I'm doing well. How are you?
Very good. We've got an interesting episode for you today. The case of the week is actually part 2 of my exclusive interview with Dr. Gordon Christensen. I don't think there's anybody in dentistry who's got their finger on the pulse of dentistry and what dentists are thinking quite like Gordon Christensen. So you're going to want to make sure you tune into part 2 of that interview at the end of this episode. But before we do that, let's go to a segment we call Viewer Mail.
This week's viewer mail comes to us from Dr. Igor Skalski from Brunswick, Ohio, and he writes, Dear Dr. DeTola, I've been hearing that some doctors are routinely using laser gingival troughing instead of gingival retraction cord prior to taking a polyvinyl or digital impression. In my mind, laser troughing, particularly in the sensitive anterior area, could cause recession in an important aesthetic area. In the posterior, recession would not be noticed. Also, any thoughts on digital impressions?
Well, that's a great question, Dr. Skalski, and that's actually something that I cover in my lecture when we talk about the best ways to do gingival retraction. Like yourself, I tend to favor a 2-cord technique in the anterior because I do feel like when I go into trough around an anterior tooth, well, let me step back. I go to great lengths to put the margin of the crown preparation just about a ½ millimeter subgingival so that you can't see where the emax, for example, crown stops and where the tooth starts. I just want that under the gingiva, just like I said, about ½ millimeter of hiding it. So when I finish the prep and I've got the margin there, what I find is if I go in with the laser and trough on that anterior tooth, as I'm trying to just remove that inner part of the sulcus, I inadvertently lose some tissue height. It moves apically as I go to try to remove that tissue. And now all of a sudden, that margin that I took a lot of time trying to get ½ millimeter subgingival is now equigingival. And so if there is any recession, it's going to expose the margin where the emax and the tooth come together. So in the anterior, like you, I do prefer to use a 2-cord technique because I know that the tissue is not going to move at all. And I feel like with the diode laser, I lose some height every time I remove it. Now you asked about recession. I don't see a lot of recession after using diode lasers. I'm actually pretty pleased with diode lasers. The only thing that I feel is that when the process of going through and troughing, what ends up happening is I lose some vertical height. So that's really more my issue. And the second part of your question was, how do I feel about digital impressions? There's a lot of good systems out there on the market now. My favorite's probably the OmniCam from Sirona, but I think all of the systems right now are at kind of version 1.0. Not the OmniCam. They've been doing this for 20 years and scanning intraorally. But I think the challenge for all these systems is to make it as easy to take a digital impression as it is with polyvinyl. Polyvinyl's really pretty simple. You know, I've timed myself many times for a single unit crown, and when I take that syringe gun and express the material around the tooth, and then my assistant hands me a double arch tray with the material in it and I put it in, patient bites together, that takes about 27 seconds for me to be able to do that. And so that's what I'm looking at. I'd like to see a digital impression system that gets close to about 27 seconds. And then all of a sudden dentists are going to look at it and go, wow, this does look as easy as the conventional way that I take impressions. There's a lot of other benefits of digital impressions. They don't shrink like a conventional impression. They don't get poured up in dye stone, which expands. And the fact that here at the lab at Glidewell, because we don't have to make a model, we actually pass on a $20 savings to any dentist who sends us a digital impression. So it certainly looks like the future of dentistry is going to be going to digital impressions. Will it be in the next 5 years? I don't think so. Will it be in the next 10 years? I don't know. It depends what kind of technology comes out between now and then. Personally, I'd love to see some sort of unit. Maybe it's a horseshoe-shaped full arch where you put it in the mouth, patient bites together, and it scans upper and lower at the same time, including the prep, and it can see through gingiva, saliva, blood, and can differentiate between tissue and hard tissue. That's kind of a dream list of what we'd like to see, but I think it's going to take a product pretty close to that for us to start seeing dentists getting rid of polyvinyl and polyether impressions. But thank you so much for your questions, two very thoughtful questions. And Megan, as being chosen as a viewer male of the week, what does Dr. Skalski win?
Not a trip to Disneyland, something even better, a signed autographed picture of you and I.
Wow, there you go. So look for that in the mail. It will be coming to you soon, Dr. Skalski, and continue viewing, and we hope to see a letter from you again in the future. Megan, you got any news stories for us today?
Yes. Spending on dental services in the U.S. is showing humble but gradual growth, according to the Centers for Medicare and Medicaid Services. The dental economy grew by 3% to $108.4 billion in 2011, up $3 billion from 2010. Consumers spent nearly $308 billion out of pocket for all healthcare services in 2011. $45 billion of that was for dental care, which was up 4% from the previous year. The CMS will issue a report on projected health spending through the year 2022 later this year.
So the total amount spent on dentistry was $108 billion, and the total amount spent by patients out of pocket was $45 billion. So what percent is that of the $108 billion? I'm going to do a little quick math. Carry the 4. It's 6,000. No, it's 41%. That's what it is. And so it used to be 50-50, and now insurance is picking up more of it. It's interesting to see that they said it grew, 3%,
sure.
A modest growth year to year. But at the lab, we were up actually about 12% last year in terms of our business. But a lot of the doctors that I talked to did only see about 3% growth, or some even stayed flat, and some lost 1% or 2%. And I think really what we're seeing is the influence of corporate dentistry. There are large dental groups now that take a lot of insurance plans, a lot of different insurance plans, and they might have 10, 20, 30, 40 different offices throughout a region, and they will really heavily market to these patients. And I think we work with a lot of these groups, and I think that they're taking a lot of the patients away from the solo individual practitioners who might need to step their game up a little bit to compete with these guys. Anything else?
Yes. A Georgia man was arrested last week after his DNA was found on a dental floss pick he dropped at the scene of the crime. The suspect allegedly attacked a man in the driveway of the victim's home and pointed a gun at him. The two got into a scuffle, and the suspect fled the scene, allegedly dropping the dental floss pick as he left. Technicians were able to match his DNA with that found on the pick. Turns out the suspect has an extensive criminal history.
Well, I'm really torn about this one. For the most part, I think those dental floss picks are pretty ghetto.
Sure.
Those ones where it's like a little sword and then the plastic thing. I don't like the idea of using the same little half-an-inch piece of floss to go through all my teeth. I like actually having the floss and being able to switch it around a little bit. So on one hand, I think those are gross. On second hand, for the guy to drop it while he's attacking the other guy seems to imply to me that he was using it. He was flossing right before he attacked the guy. And that's impressive because we've talked before about how men don't like to floss.
Sure.
And I think that's pretty cool that this guy was flossing, had a minute to kill before he attacked this guy.
Right.
And decided to go ahead and floss. And then the guy puts back a little fight and he drops it onto the ground. And so he ends up getting caught.
Sure, and it sounds just like another episode of World's Dumbest Criminals, and it's either that he was flossing right before he committed the crime, or during, what if he had it in his mouth during the crime, or possibly it was in his pocket from previous use. Maybe he was in his car, about to go attack the guy and had a quick little floss. But regardless, it's ridiculous.
And yeah, I hate to think it was in his pocket and he was actually going to reuse that. But again, it looks like it's shaped like a sword, and perhaps he thought he could use it as a weapon, right? Something a stupid criminal might think. Sure. All right, thank you very much for that news. Now let's go ahead and take a look at the case of the week. It's funny you mentioned EMAX. We breathed a little bit of sigh of relief here when it hit the 5-year period, because for me that seems like a good clinical signpost that if it lasts 5 years without a ridiculously high remake rate, things are going pretty well. But what we've seen here in the laboratory in the last 6 years is a type of sea change that's really stunning. If you just turn the clock back to 2007, 65% of the crowns that we made here were PFMs, and about 21% were all ceramic crowns. And then you go to last year, 2012, and all of a sudden PFMs were down at 20%, and all ceramic crowns at 73%.
Is that amazing?
In 5 years. I mean, it's just such an amazing flip over to these monolithic, high-strength, cementable all ceramics like the Emax and Bruxer.
Rightfully so. I always judge the validity and potential success of any product, and we've been evaluating products for 40 years now, on the basis of how fast they integrate. You take the air rotor, it integrated in 6 months.
Right.
You take in-office milling, although it's wonderful, it's been 28 years now, and it's still a fraction of the population. We tried to figure out why, but going back to this paradigm shift, it's the fastest thing since the air rotor.
Since the air rotor.
So we're going to see monolithic all ceramic crowns dominate. I'll give it another 5 years. PFM will be like W.D. Taggart in 1906.
On the endangered species list.
Yeah, it is.
And you know, I do think it's a benefit for the patients because we've done studies here where we measure the average occlusal reduction that we're getting from doctors. And this is 10 years ago when PFM ruled the roost. And the average occlusal reduction we got on these 200 posterior crowns that we measured was right around 3/4 of a millimeter, where every manufacturer for a PFM or any bilayered restoration has been asking for 1.5 to 2 millimeters of reduction, and they simply never got it. And in fact, when you do a hands-on course and have a doctor do occlusal reduction of 2 millimeters, they think it's iatrogenic dentistry. They go, well, that looks like malpractice. I go, well, that's what the manufacturers and the labs have been asking for years. So it's nice to see that we have new materials that will adapt themselves somewhat to the prepping habits of dentists, and so I think that's a big benefit for the patients as well. You were nice enough to go with us to dinner last night, and you asked the question, why do you think zirconia is growing faster than Emax? And there was actually an image that I wanted to share with you because it took us a while to figure it out why it was going to grow faster than the Emax was, because the Emax, as you said, is a gorgeous restoration, and it's pretty darn strong on its own. You can't use it for bridges, and you probably don't want to use it on a lower second molar with 1/2 millimeter of reduction, but it's a very strong aesthetic material. Why would the uglier material pass it up in terms of sales? So the interesting part of it was dentists would tell us when they got their Bruxer crowns, these crowns fit better than any crown I've ever got from you guys. And we're thinking, we milled these the same way that we milled Emax.
Yes.
Why are these fitting better? They shouldn't fit any better. And it took us a while to figure out what they actually meant by fit, because they didn't necessarily mean what we thought they meant. And so we took a typical tooth as the one you see here and sectioned it with a PFM crown with the feather edge margin that we tend to get from most dentists. And of course, on a bilayered crown, we've got metal, opaque, and ceramic material. And we've got this big speed bump, this bad emergence profile. And so when the dentist tries this in and goes to check the fit at the margin, his Explorer invariably gets stuck on this huge lump that's here. And then you take that same tooth, that same preparation with the feather edge, and because of how thin we can make the Bruxer material, and Emax does not like feather edge margins. It wants a chamfer margin, it'll chip. And that same margin, that same crown prep that the doctor did, he drops a Bruxer crown and checks the gingival with an Explorer, and now all of a sudden it feels like a gold onlay did from back in the mid-60s when those things were perfect. And we realized all of a sudden this is what they meant by fit. We finally had a white material we could take to a feather edge so that when they checked it with their Explorer, they wouldn't feel that big bump. And that, I think, is the reason why dentists have been drawn to this, because they didn't have to change their prep at all. They could still minimally reduce and have a restoration that feels almost like gold would, because it can be taken down to a feather edge margin. Yes, it's stronger than an Emax crown, but a dentist doesn't know that. They have to take our word for it. There's no proof of that practically that they have. So I really believe it's that fit aspect, and that's one of the reasons why I think this is going to benefit patients. I love the idea of not having really bulky, emergence profiles on patients interproximally in the posterior areas of the mouth. We all agree gold is still the best restoration in dentistry, right?
But the ugliest.
But the ugliest, yeah, exactly.
No question, yeah. I've asked many groups of dentists over the years, how many have gold? And it'll be 2/3 of the group. And then I will say, okay, would you have gold again? And most will say yes. And then I say, well, we speak with forked tongue. We speak with cognitive dissonance. We know that gold lasts longer, but we don't promote it to patients. They don't want it. It's ugly.
Well, it's funny because the first, part, even before Brux or even before Emacs, when the R&D department came to me, when it was formed here at the lab and said, what should we start working on for you? I said, I've got one request and one request only, a cast gold and a shade A2. That's all I need. I just need cast gold, and I need it to blend in reasonably.
You can't get that.
You can't get that. They said we're not alchemists.
No, and
we're
then
just
with
engineers.
gold at 1,700 and some odd per ounce, there's no way. I should have bought a ton of it back when I started dentistry, and it was $32 an ounce.
Exactly.
I missed the boat.
And held on to that until now.
Yeah.
For dentists who maybe aren't familiar with the term, you've used it with us talking back and forth. You have always had this desire for to use your word, a Volkskraun. And this would be, I think Volkswagen meant a car for the people.
Yeah, for the people.
So you were looking for a crown for the people. In other words, something that would not be so expensive, like $1,700 an ounce of gold, that would allow dentists to provide it at a lower fee, still make a good living, but be able to provide dentistry for people who might not be able to afford to go to a boutique dental practice, for example. This is our first attempt at the Volkskraun, and I know that it's going to continue to improve. How do you think we did, and what else would you like to see in your Volkskraun?
You have asked a very, very good question, and I've thought about it a long time. I've talked with many restorative dentists about it. Where are we right now? We've done a lot of research on Class 2 resins over the years since 1968. Computers didn't even come until the 80s, so we had computer data from that point on. And here's what we see. And the international meta-analysis will show a Class 2 resin only lasts about 6 years internationally.
Wow.
And a crown, decently done, a porcelain fused to metal, 20 years, not aesthetically, but functionally.
Right.
Now here's the challenge. In the middle of that paradigm, we don't have anything. In other words, they can go to an Emacs, they can go to a milled onlay, but few go there. I ask Tom Lamoli of Lamoli Associates, I asked him, what was the percentage in third-party payment last year of onlays? 2% in the U.S. So that the middle of the road restoration is still unsolved. We have a poorly serving Class 2 resin, unless it's a small hole. Right. Small hole will go on 20 years. 1/4 of the cusp tip to cusp tip distance. You get up to half of the cusp tip distance and you put a composite in there, it'll fail very rapidly. Right. You jump to the crown, it'll go longer. So right in the middle, we're still a void. We need something that would fit that middle of the road situation. And Glidewell did a group of onlays for us in a study, and we showed that Bruxer or Emacs done with a covering of the cusp onlay orientation was stronger than a virgin tooth. And I know the typical dentist will go in and cut down the facial surface, the lingual surface, and put a crown over it and leave just what was in the middle, which was old amalgam or whatever, and not consider the onlay, which they now can be paid for either as a ceramic crown or even with the resin nanoceramics as of January 1, several days ago. They can now code that as a ceramic and be paid for it. So I would like to see more emphasis on the partial tooth restorations done in a less expensive way. We have a challenge, however, and that is the dentist going to pass the savings on to the patient? Right. And I'm a little skeptical. Right. Because there's a set fee of whatever it is in the practice, and the lower the lab fee goes, the clinical fee tends to stay the same. So I'm a little concerned about that. I can see if I were a young buck dentist just coming out of dental school, it would be so easy to set up a practice with a couple of milling devices and a couple of helpers, and they could be computer gamer kids, they could be hygienists, they could be lab technicians, and do extremely well with a low fee. Let's just pick a typical crown fee today of say $1,000 or $1,100 or $1,200. Let's put it at $400 or $500, which would be twice the level of a Class 2 composite, and still do very well financially with auxiliary help. So that's what I see as the lacking area, is the partial tooth restoration, where they'll huck a big chunk of composite in and then wonder why it failed in just a few years.
Right.
We need Rella, my wife's terminology of Volkskrone, she started that. Her thought is, why aren't we using these materials in partial tooth restorations, not just as crowns? And then the dentist will say, well, they're harder to do. The prep's harder. Not if you do a bunch of them. Right. They're not harder.
Temp falls off too much.
Yeah. Well, that's true too.
There's just another objection. And if you look at our numbers, inlays and onlays, sadly, are 1%.
Are they 1%?
Of what we do here.
I imagine nationally it's 2% because 8% of the dentists have a Sarac or an E4D.
Exactly.
And perhaps a Glidewell one eventually. But in the meantime, that group is the group that's doing the onlays. They've determined the value of a partial tooth restoration, and our little study that showed the strength stronger than a natural tooth was really unbelievable.
That is amazing.
Yeah.
So it turns out the Volkskrone may not be a crown after all. It may be an onlay.
Could be an onlay. But then I have a few disagreements with some of the Sarac and E4D prep designs. Many times they will take a tooth with 4 cusps, 5 cusps with a cusp of Carabelli, leave one sticking up. Our research showed we couldn't even turn the Instron on before that cusp broke off. An onlay ought to be an onlay. It ought to be a new roof. It shouldn't leave one
No reason to
pillar
leave 3 enamel rods on the distal lingual.
No, but that's the preps they're teaching.
Right.
So,
and is that truly conservative if it breaks 2 days after you bond the restoration into the patient's mouth?
I went to USC many years ago, and USC taught onlays back then of gold. Then I went to another school in the Northwest that taught for graduate school and for my PROS program, and they taught inlays as one of their major things. Now, many years later, several decades, I've watched thousands of my own restorations, inlays, onlays, crowns. Obviously, the crowns go the longest, at least from a structural standpoint. The onlays do exceedingly well. The inlays don't. As soon as we leave a cusp sticking up here and there, eventually that cusp goes. But this bonding fantasy that everybody's into, we're going to bond that together. Yeah, right, for 15 minutes till you hit coffee, ice cream, it falls off. We need onlays. And although third party will now pay for one cusp covered and call it an onlay, I think it's a fantasy. We need a little more coverage.
Right. I agree, and it does seem to be an ethical dilemma, and you wonder what would happen had dental insurance, say, never come along. I talked to my dad, who practiced from 1960 for about 30-some years, and he said 50% of the fixed restorations he did were inlays and onlays, gold, and they served fantastic when placed in the right ways. And then we see this shrinkage down to 1%. It's a little bit heartbreaking because you know that it's more about dollars and reimbursement from insurance than it is about what's best for the patient.
And color. Now, Rella, and many of you listening to this video know her. She's probably twice as smart as I am and very knowledgeable in dentistry, although not a dentist, a PhD. Recently, she said, I don't like that gold in her mouth. And it was a foil, and it had been in 52 years. And when I put it in 52 years ago, and it was still virgin, I cut it out.
Really?
Yeah, she wanted a white one in there.
I had that same thing with my mom. She made me take out gold inlays my dad had put in and put in Empress, and I was like, I said no the first 3 or 4 times.
Well, I did to Rella.
Right.
I played like I didn't hear her, but then eventually I had to take it out.
Wow, that's funny. A 52-year-old restoration. Yeah. I thought our lower lip started to hang down more the older we got. But she does have a great smile, so I guess she was able to see it from time to time. Yeah. Well, and that's really why I ended up replacing those restorations on my mom too, is because you can't force longevity of a restoration onto somebody whose self-esteem is being affected by a restoration.
It's like hair sticking up or a pimple or a scar or a birthmark or whatever, they want it off.
Right.
They want to look normal.
And in fact, that's how Bruxer started. Was when we came up with it and started using it, the first ones we did were pretty ugly. They had no translucency
They kind of looked like a bar of soap that had a crown card.
Exactly, or it looked like, they would shine sometimes in the light, look like the inside of an abalone shell as well.
They were ugly.
And they were ugly, but then they started getting better looking, and then we said, okay, this is good enough to send to a dentist. But the first thing we did was we took dentists who had ordered a cast gold crown and we said, hey, we're just sending this other one along as well. Yeah. Here's how strong it is, here's what it does. Just show both to the patient and see which one they want. And,
was there any question?
And yeah, they always pick that one, and the dentist will say, well, but that one doesn't even look like a tooth. It looks like it's carved from a bar of soap. They go, you think that one looks like a tooth? The gold one? Nothing like a tooth. So patients showed that they want a white one, regardless of how much it looks like a tooth, versus the other one. So we can't force gold on people, and we probably shouldn't force PFMs and other things. And it's nice that we finally have some cementable, high-strength, all-ceramics.
In fact, patients don't even want the little groove stains in their crowns. While I was living down here for a couple of years on a church mission, I did dentistry one day a week. We did a little survey among socialite-level women in their 40s. Showed them crowns that had grooves but no stain in, crowns that just had anatomy in. Which do you like? What's that color in this one? There was no question. They don't even want the groove stain.
I had a patient call me out on that once, and she pointed to it and she said, what is that? And I said, it's some stain in the top of the crown. She said, why is it there? I said, because it matches the stain on the tooth next to it. Yeah, yeah. You know, she goes, well, I don't want it there either. You know?
Well, it's just like saying I got a basal cell carcinoma. Let's just put some makeup on it, you know, and we'll cover it over. But no, you better put one on the other side so it'll match. Unbelievable.
That about wraps it up for this week's edition of Chairside Live. Once again, I'd like to thank Gordon for coming onto the set and spending some time with us. On behalf of all of us here at the laboratory, Megan and myself, I'd like to thank you for your time and your continued commitment to quality dentistry.
Thanks for watching, and come back next week when we have part 3 of our exclusive interview with Dr. Gordon Christensen.
If you watched last week's episode, you can probably guess it's part 2 of my exclusive interview with Dr. Gordon Christensen. And he's such a great knowledge base. I gotta go. Yeah, Megan's reading the news. All right, I'll talk to you later. Bye.
Thank you. He writes, Dear Dr. Totola, I've been hearing that some doctors are Seriously?
Retuning their guitars.
Right.
In the key of U.
I've been hearing that some doctors are routinely... Really? Routinely? Dang it.
Are routinely mispronouncing the word routinely.